I would like to introduce our first speaker, Dr. Brad McAllister. Dr. McAllister is a periodontist in private practice in Portland, Oregon. He's involved in research aimed at enhancing regenerative outcomes for the past 25 years. He has published numerous papers and presented his research on a variety of regenerative approaches, including BMPs, PDGF, and cellular bone allografts, which is the focus of our webinar today. Dr. McAllister, with that, I'd like to turn it over to you.
Grafts. We'll follow with case presentations of cellular bone allografts that I've performed. We'll look at some of the advances that we've seen in these cellular bone allograft products. And then we'll touch on the uniqueness of Oragen, which is the new product that is specifically for dental from LifeNet that we're very excited about and our group has been working with. We're then going to have Dr. Mike Hartman and Dr. Gail Childers go ahead and share their presentations and their histology, followed by a question and answer panel discussion. So my personal journey for complex regenerative cases, and I'm referring to those more difficult 5%, first started out with autogenous intraoral bone, things like block grafts or particulating grafts that I'd harvested from the symphysis. I then moved to autogenous extraoral bone for a period of time because I felt that the cellular component was critical. And we would harvest from the hip, from the tibia, and I will say that we found some amazing results, but the morbidity, especially with extraoral bone harvests, was fairly significant, even more significant than intraoral bone. While I was fortunate that we never had any major complications, patients did complain of the host site that we harvested from. I then started adding PRP to my grafts and certainly helped in the handling, and there was some early evidence to support that it stimulated better soft tissue healing. Then I got excited about allografts. All of the new allograft configurations that came on gave us all sorts of ability to do off-the-shelf grafting of even complex cases. And then we were able to make things even better by adding PDGF with membranes. And then the cellular bone allografts came on board in around 2007. And first I used those with no membranes, and now I'm using either allograft with PDGF or cellular bone allografts. And I'll typically use either titanium mesh or perforated membranes, and that gives us the optimal vascularization. So obviously what's driven this evolution is extraoral bone has high cell content, intraoral has a little lower cell content. Obviously most of our autografts have the osteoconductive, osteoinductive, and the osteogenic component, but it varies site to site, and there's obvious technical challenges, longer surgical time, limited supplies intraoral, and that donor site morbidity, which has continued to drive us towards allografts. Now, do I still use autogenous bone? Yes. Routinely, I'll add small volumes of locally harvested autogenous bone to my classic bone graft materials, such as allografts and xenografts, and that helps optimize my results in the less complex bone grafting cases. But again, for these 5 to 10% of the more complex perio and implant defects, I currently primarily use cellular bone allografts. So I'd like to kind of share our findings with you regarding that product. Now, the whole concept of using cells has been one that I've been chasing for over 20 years. This is a publication we did about 25 years ago where we were using basically mesenchymal stem cells. At that time, they weren't called mesenchymal stem cells. They were just called human osteoblasts. And we were amplifying them in vitro and then putting them in different scaffolds to use ultimately for implantation. So it was a great strategy because obviously if you could amplify the cells, you could take a small biopsy and you could get very large numbers. The problem that you have, especially with autologous, is it's such a high cost to harvest and to grow these. Plus there's the FDA clearance type issues. So that strategy is stalled. And what we have found is that the allogenic approach, which gives off-the-shelf availability, reduced cost, improved manufacturing, that has been sort of the focus over the last 15 years. And that's given us these cellular bone allografts, where basically we can take cadaver-derived tissues, much more cost-effective, with obvious fantastic results. So these cellular bone allografts contain osteoinductive materials, osteoconductive, they have a beautiful scaffold, osteogenic, and that they have cells, including osteoblasts, osteocytes, osteoprogenitor, and stem cells. So this is the key clinical results, or should I say, literature for the different areas. Orthopedics is in white, implants is in green, perio is in yellow, and specific papers that are related to the Oragen research has the purple. And you can see that since 2018, there's been a lot of emphasis and a lot of research that LifeNet has done, and I'll share a few of those papers along with some of the papers that I have done. But it is exciting to see how much dental research has been done with the cellular bone allografts. You can see that the dental research has exceeded what we see in orthopedics. So my first paper was back in 2009, where we did sinus grafts and then we did biopsies. This just shows an eggshell sinus, typical lateral wall approach. This is the bone graft material in place. No membrane was used over that outer wall because we want to rapidly revascularize that bone graft, and we didn't see problems with any kind of encleftation without a membrane, which oftentimes you do need to use a membrane when you're using classic bone graft materials, which can take quite some time to actually mineralize in a eggshell sinus like this one, where there's basically 1 millimeter of host bone on the floor. So this is day one. You can see a few voids where the blood clot is not completely filled. And then this is at 4 months, and you can see tremendous mineralization. And most of this is found to be actual vital bone based on our histologic results. We then followed with a multi-center study with some of my colleagues, Arun Ganshore and Steve Wallace. Hari Prasad is the one who did all of the histology. He's a wonderful histologist. So the results from these bilateral cases showed 33% compared to 18% with allograft alone, nearly double the amount of bone formation at 3.7 months on average. There was also much less residual graft. In other words, when you have a cellular bone allograft, it's a very rapid bone formation and a rapid turnover of your graft material. That's compared to 26% when you use classic allografts. This is one example at 4 months, and this one had a 36% vital bone area and a residual cellular bone allograft area of 6%. When you look at higher magnification, you can see the green is the demineralized bone areas that have new bone formation, and then you can see the red, which is the new bone formation. This study was repeated most recently in 2020 by a group out of Kentucky, and they saw very similar results where they had almost double the amount of bone when they utilized the cellular bone allograft. Their numbers were a little higher than what we did, both for the control and for the test cellular bone allograft, but this can be attributed partly due to the fact they use demineralized histologic techniques. Demineralized techniques with H&E staining can be difficult sometimes to measure the amount of vital bone. As you can see in this slide, it's a little trickier to identify what's vital bone and what is graft material. But clearly it showed an accelerated result at the 4-month time point, which further supported what we were seeing clinically. I then moved into periodontal type defects because I thought, wow, if this can perform so well in sinus lifts and ridge augmentations, hopefully it could work in periodontal defects. So this is one example that you can see quite good bone formation interproximally. We published this in 2011, a case series. Another example was a severe class 2 furcation that we used the cellular bone allograft, no membrane, pretty uneventful healing. And on the right shows what the furcation originally looked like, and on the left is the closed furcation after 4 months. Clearly, the best way to evaluate furcations is with CBCTs. This CBCT shows that we had complete defect fill all the way to the roof of that furcation. And that, again, was a very dramatic furcation. That was a tooth that probably should have been considered for implant placement, but we did see some very nice results. And that tooth is still here 10 years later. We also published in 2015 as part of the AAP Regenerative Conference a few more cases for perio. This is an example where a hopeless tooth was removed, and it did give us the opportunity for a re-entry. You can see tremendous defect on the tooth number 22 on the right-hand slide. And you can see this was a through and through defect on the lingual as well as the buccal. So both challenging for the implant placement that was to follow and challenging from a periodontal standpoint in that the canine was compromised. Due to the through and through defect, this case I did use a membrane because I was worried about the soft tissue considerations, very thin soft tissue. Typically, I don't use the membrane unless I perforated it. These slides show that we've got radiographic evidence of bone, and you can see that the bone on that canine is actually more coronal than that original defect. So tremendous ability to regenerate the periodontium, which was very exciting. And we've used this in numerous cases for periodontal regeneration, and others have published as well. My good friend, Dr. Paul Rosen, published in Clinical Advances in Periodontics in 2013. I had some very nice results showing closure of class 3 bifurcations. And then Dr. Rich Gao, our past president of the AAP, had a paper where they looked at a very large number of cases, and they found 5.5 millimeters of improved cal at 12 months. That's pretty impressive. We know from the periodontal literature that it's very difficult to get much more than about 3 millimeters. So if you're able to get 5.5 millimeters, that's on par with the best of the literature that we've seen. Now, I moved on beyond periodontal defects that are sort of the classic infrabony to looking at buccal plate defects. And some of these defects are very complex, and soft tissue grafting alone is probably not a good strategy. I published on this in 2018. Some of the key papers prior to would be Dr. Mike McGuire's paper of 2008, which had histologic evidence using PDGF to get a buccal plate with full regeneration. That was followed by Dr. Jeff Ganellis' paper in 2012 using the same PDGF technique and seeing some very nice root coverage. This shows the CBCT at pre-op, and this shows the bone grafting, and you can see very little buccal plate on most of these teeth. Luckily, orthodontia was performed to try to get that buccal prominence reduced on the tooth that had the most recession, so we were able to tuck that back in to the bone, use our cellular allograft and a membrane, and you can see on the bottom left slide that we had complete root coverage. And on the CBCT in the center, you can see that we had several millimeters of buccal bone growth and hopefully regeneration. On the right-hand slide is approximately a 3-year follow-up, and it was kind of interesting to see her home care certainly was not ideal yet. We were maintaining that root coverage, even with less than ideal home care. Another example that sort of fits in line with the periodontal application is the treatment of periimplantitis. We know that periimplantitis can be very significant and difficult to treat. So this is a case where we used kind of classic techniques for detoxification of the implant. And then we used the cellular bone allograft, which is also going to help on the adjacent tooth. And you can see while we've lost our papilla, we did maintain excellent bone on the adjacent tooth and on the implant. So we have been very successful treating periimplantitis. For ridge augmentation, I tend to like titanium mesh. We published on this first in 2013, and we've had subsequently some additional papers, most recently one in 2022 with my good friend, Dr. Robert Levine. And in this most recent one, we had on average 4.7 millimeters of horizontal mean gain. And what was interesting is that 56% required supplemental bone grafts. So I do think even with 4.7 millimeters of horizontal gain, a lot of these cases to get the implants in the correct position will require supplemental bone grafting so that there is at least 2 millimeters of buccal bone over your implant. These are a couple of examples using titanium mesh. This had about 2 millimeters to the floor of the nasal cavity. We used our cellular bone allograft with the titanium mesh. Uneventful healing. Used a temporary that did not put any pressure on the mesh. And you can see radiographically that we had good bone formation. At the time of our removal, we were able to place our implants and our final restoration. Another case, this is posterior mandible. First, a soft tissue graft was performed to enhance the keratinized tissue. Our titanium mesh was placed with the cellular bone allograft. gaining both vertical as well as horizontal bone. This is at the time of implant placement. And this is at the time of restoration, showing nice vertical enhancement as well as horizontal enhancement. A contour graft was performed on the anterior-most implant. So when we're using tie mesh or membranes with perforation, I do believe we get more rapid revascularization, which can lead to improved cell survival and ultimately more rapid bone growth. So there's a variety of different ways that you can perforate membranes, as shown on the left. The goal is to make sure that the revascularization does not look like it does on the right, and that's an occlusive membrane that basically stopped the blood vessels, and you can see that the ability to revascularize would be very limited. That's why I'm not a big fan of using regular membranes. This is another view, just kind of a schematic to show the potential revascularization when membranes are perforated. Here's a case that was an anterior maxilla, and a resorbable membrane was used with perforations and the cellular bone allograft. And you can see excellent bone fill, both on the CBCT in a vertical dimension and horizontal dimension. So hopefully these cases have shown you that certainly cellular bone allografts can do quite a good result for you. And I'd like to touch a little bit now on the different configurations. One of the concerns is that the large particle size is somewhat difficult because it's been designed for orthopedics. So sometimes we will use rongeurs or pick out the larger particle sizes for our dental application. Smaller packaging sizes, that's something we're working with LifeNet on for dental applications, which is exciting that they're willing to make a smaller packaging size for some of our smaller defects, such as periodontal defects. There is a demineralized component, which is the fibers that gives excellent handling. And that demineralized component ratio is partly what controls the formation of our bone. One of the things that we're also working on is custom cellular blocks. So that is something that I think would be very exciting from a dimensional stability standpoint and would maybe eliminate the need to use titanium mesh, which certainly can be complex. This is a paper using the Oragen product. It is also called Vivigen in the orthopedic arena. And in this particular one, they compared to Trinity, and you can see with ankle fusions, they did actually see a significant improvement over that product. And one of the reasons that they think they may have seen this improvement is the fact that there is a severe increase in the cortical component, which is the osteocytes, which we know can play a big role. Now, advances in cellular bone allograft preparations to minimize the risk of disease transmission, things include donor screening. With LifeNet, only 2% of the donors are accepted, extensive battery testing by the tissue banks, a wash procedure, antibiotic treatment, and the enhanced AATB guidelines, which helps minimize the chances of any kind of disease transmission. So specific to Oragen, the packaging is a very rapid thaw, which you'll see, I think, in a video that Dr. Mike Hartman will show us. The cortical component gives great dimensional stability. We know we have, again, the presence of the cortical component with osteocytes, and the fibers give it great handling. This shows the actual packaging, and this is a schematic showing the bone chips with the demineralized component. We do know that there is a critical role for osteocytes, and this is in fracture healing as well as with the cellular bone allografts. So I've become much more a fan of the importance of osteocytes, and I do believe that's one of the main reasons that we see such excellent results with Oragen. So this is one of the papers using Vivigen, and this showed at 7 weeks that there was excellent bone in the hip. This is another paper that gives all sorts of great characterization information. And sounds like Dr. Janal is on the phone with us today, and she can help us with any questions people might have on the characterization. The slide that I chose here was to show alizarin red staining at days 7 and 14 compared to mesenchymal stem cells. And you can see that mesenchymal stem cells oftentimes don't mineralize unless they have a signal. So very robust result when the alizarin red shows the Vivigen as far as the cells coming out and mineralizing. So I'd like to show a couple of my own cases of Oragen before I turn the mic over And this one was a peri-implantitis case where the implants were actually treatment planned by another provider for removal of all three, and the patient came for a second opinion wanting to save these implants. We went ahead and used Oragen around these implants. And this sequence of CBCTs gives you a pretty good idea that we were able to regenerate not only a significant amount of horizontal bone, but the density is what I'd like to really have you highlight. This is at 6 months, and you can see that the density of the bone on that buccal is quite significant. And that's one of the things that I've repeatedly seen is excellent bone density and excellent dimensional stability, which is really important with our cellular bone allografts. Another case, I used the osteotomes to expand this site. It wasn't wide enough for the implant, so you can see the bone essentially cracking right over the implant. It was also narrow ridge over the teeth, so I grafted not only the teeth, but the implant. And this is a CBCT showing an excellent buccal plate that was developed and are 2 millimeters like we like to see to maintain excellent long-term health and gingival architecture. One more case. This is one where it was a bilateral sinus case, and day of surgery versus 4 months, you can see significant mineralization. And our histology showed that there was excellent bone formation, very active formation. The red, again, is our active bone, and then light green is the osteoid. And you can see at the high magnification, especially on the right, you can see high activity and lots of new bone formation. So I know that was a bit of a whirlwind, hopefully showing you some literature, some cases, telling you a little bit on the technical standpoint of Oragen will help you. We'd like to now turn things over to Dr. Mike Hartman. He's an oral surgeon from Mechanicsburg, Pennsylvania. He has a passion for digital implant technology and bioprintable regenerative materials. He's currently a consultant on research funded by the Maryland Stem Cell Research Fund, and they explore a novel 3D printed hybrid graft material. He's got over 8 years of experience with LifeNet Health regenerative products and recently integrated Oragen into his practice. He's dedicated to improving patient care through innovative approaches to bone grafting. So I'm looking forward to hearing your presentation, Mike, and I'm going to go ahead and do my stop share.
Nice cases that you shared with us. Hopefully I can kind of follow that up here a little bit. Good evening, everyone. As Brad said, my name is Mike Hartman. I am a private practice solo practitioner oral surgeon here in Mechanicsburg, Pennsylvania. And sort of as a little disclosure here, I'm also president of a dental laboratory called Digital Provisionalization Technologies. I'm also a Dean's faculty member down at the University of Maryland School of Dentistry. I actually started down at the School of Dentistry a few years ago because I got a big interest in 3D printing through the use of 3D printers in our dental laboratory. And I started to think, well, what's really to keep us at some point in terms of being able to develop bioprintable materials, and I had an idea, and I took that down to the school, and we've been doing some research in terms of bioprinting for the last few years, and now we were fortunate enough to secure a grant through the Maryland Stem Cell Research Fund that's helping us continue our research further. This is a very exciting time right now, I think, in the field of regenerative medicine, not only from some of the regenerative products that are available to us, but also the ability for us to sort of merge this dental or this, digital technology into our further advancement in this area. It's through this kind of bioprinting sort of rabbit hole that I went down. I kind of heard of this cellular bone allograft material that LifeNet had. Initially, it was called Vivigen when I kind of caught wind of it in terms of having these bone lineage committed cells. And I thought, well, maybe this might be something to use in some of our larger defect areas, sometimes I tend to avoid, honestly, trying to augment areas like this in the posterior mandible. We have this pretty big, significant saddle defect where you're hoping to gain a fair amount of vertical bone augmentation. So this was actually my first case that I had used with, at the time it was called Vivigen, and now since it's transitioned similar or same product now to dental called Oragen. And how I set this case up was I had sent away and had a custom or patient-specific tie mesh space maintainer here made that I knew was going to fit very accurately over the deficient area. And my picture on the right here is my Vivigen mixed up with some PRF and then the overlying titanium cage there, just to sort of show the materials that were used. At the time of surgery, you can see the axis there on the left-hand side. I've been finding that these patient-specific tie mesh space maintainers fit very accurately, so it's in place. It's pretty secure. I don't really use the sort of the holes that they make on the border of the plates. I tend to just kind of drive longer screws through and through, and typically use about 2 as long as we get some good primary stability. I'm pretty happy. And I did use a collagen membrane in this case, just sort of my fear for the potential to hopefully reduce the tie mesh exposure. This is the money shot on the right-hand side. This is, I let this graft to mature for 6 months. Real nice coronal section showing that we maintain the width at over 12 millimeters, and we're able to augment vertically about 4.2 millimeters. I didn't notice this until today when I was reviewing for the presentation, but keep note of that 4.2 millimeters here. It'll come back up in a couple slides. At the time of the mesh removal, clinically, the bone looked like it was well healed, as seen on the picture on the left. I thought, after reviewing the CBCT, that we were going to get a pretty good bony healing. So I asked LifeNet, I said, hey, if I harvest the core sample here, would you be willing to do the H&A, the histology staining for us to review? They said, sure. So I used a 2 millimeter trephine. This was the initial implant osteotomy of one of the sites. And then the core sample there on the right. So we had a chance to review the H&E stain after it was processed with LifeNet, and you can see a longitudinal slice of the core sample at the upper left, and that's measuring out at 8.4 millimeters. Now, if you go left from right, you can see the native bone, followed by that dense lamellar area there. That's the cortical bone or the junction. And then sure enough, the graft material measured out same as 4.2 millimeters, same as it did on the CBCT. I'm not really a histologist, I'll tell you that much, but the native or the graft bone looks very similar to the native bone to me, and it makes me happy. And I'll tell you that clinically the bone was very, very dense. If we look down to the blow up and those particular rectangular areas of the specific shots, and I'll expose or I'll enlarge the one here with the arrows. You can see there's osteocytes now in the lamellar pieces, and we have new angiogenesis in the area as evidenced by the blood vessels. I did this case about 2 years ago, so I do have 1 year post-op CBCTs on the patient. The implants are well integrated and look within normal limits. After this case and allowing this to mature and getting pretty good results, I started to use the Oragen material in various other applications. I'll say that I do tend to reserve the Oragen for maybe larger defects or more complex cases, especially the ones that I use with the tie mesh space maintainers. One of the nuances of the product is because it has those lineage committed bone cells that they're cryopreserved, and they need to stay very cold at minus 80 degrees, and that's typically something that you store in a what they call ultra low temp freezer. I didn't have an ultra low temp freezer because I don't have anything else, any other products that I needed it for. So these first couple cases, I had to logistically do this through LifeNet and arrange for overnight shipping of the product. And honestly, that's fine. There's no hangups with that. It's very smooth. And I trust that the shipping's going to arrive on time. The thing that I don't always trust, to be honest with you, is, well, will the patient show up that day? And, you know, it's can be a little bit of a challenge if the patient maybe gets ill or has to cancel their appointment at the very last minute, or just, you know, decides not to show up. As long as you don't open the inside packaging, LifeNet does allow you to return it, but that's just sort of a, you know, couple more steps in the office that your staff has to deal with. So we did buy the ultra low temp freezer. And a couple sort of pearls with that, things that I look for. It has a very small footprint. So, excuse me, it doesn't take up a lot of space in your office to set it up. I kind of keep mine on this wheeled cart now, because sometimes we kind of move it from area to area depending on our space needs. It's pretty quiet. It's not super loud. It holds, or it can hold, about 10 or 12 boxes of the Oragen material at one time. What's pretty good about this then is if you buy in bulk, I think like 4 boxes at a time, then you get a pretty nice discount then on the purchase price, which helps obviously with your overhead, but then it also helps offer this to your patients at a little bit of a better price. In my office, in order to kind of keep our staff engaged, we like to shoot a lot of content during our surgeries, and that kind of gives us fun stuff to do, but it also gives you the ability to kind of critically analyze yourself working, which is never as good as what I think it is. So I shot this video here last summer on another case that I done, and really the whole point of this video, honestly, is kind of show potential Oragen user in terms of how our workflow is in the office with the Oragen product. So this was an upper right extraction case, basically, with a bunch of failing root canal teeth. See my one assistant here is popping the top on the ultra low temp freezer. The box the Oragen comes in itself isn't really that big. There's this outer lining then that you have to grab sterilely. And then we just warm this up in 95-degree water. Now, key point with this is you can't let it thaw really for longer than 5 minutes, or else it can disrupt the preserved cells. So warm for 5 minutes, then you can lay it on the table. It can stay in that packaging. The label says for about 2 hours. And I actually don't open it then until we're ready to use the material. Here we're just removing those teeth on the upper right. Some cool shots here. There was no sinus involvement with this case. The abscesses were big, but there's still a bone between the defect and the sinus floor. So I take this 10 cc sterile syringe. It's like a lure lock adapter on top of the Oragen packet. and basically try to extract as much of this cryopreservative as you can. Admittedly, a lot of the times those demineralized fibers will kind of go up there and clog that. So you get as much out as you can, and you can just stop. I'll cut the top off there with scissors. If there's a lot of fluid left, typically take a piece of sterile gauze to the top of that and just kind of wick some more of that preservative away. That's a pretty good shot there, showing the cancellous chips as well as the demineralized fibers. And we just kind of pack it just like you would do with any of your other kind of allograft material. The packet itself is it's labeled as 1.3 cc's of bone. So what does that get you? How much defect can you augment with that? Well, I will tell you, in my hands, it's 1.3 cc's is probably a little bit more than 1 molar site. It might be good for maybe 2.5 molar sites. In this case here, we used 2 packets, so 2.6 cc's of it. And then I just cover this with one of those thin amnion corium membranes. I got a pretty decent closure, tension-free closure, then just sutured it up with the chromic suture. So this patient did very well post-operatively, really no big deal. And we're in the course of implant therapy now in the upper right. So in conclusion, for my part of the talk here, basically kind of the key point to remember, it does have this osteogenic potential, which is somewhat unique in the regenerative tools that we have in dentistry. It's with those lineage committed bone cells. And since they do have the lineage committed bone cells, it requires a unique storage solution, which is in this ultra low temp freezer at these ultra low temp materials. You can create this workflow in your office very easily with minimal staff training. I find that it doesn't really add any additional time to the procedures that I do. We call the Oragen in our office, freezer bone, basically. And when I say, hey, we have a freezer bone case coming up, everybody knows what to do. We know what time that patient's coming in. One staff is responsible for heating the water and making sure that the water is in the right temperature, and then pulling the graft material out of the freezer at the same time. It goes off flawlessly, and honestly, it's not a big deal to implement. And I'll tell you, the results are rather impressive. So my advice would be do a couple cases, get familiar with the material, make sure that it's working well in your procedures in the way that you want to use it, and then start looking around for an ultra low temp freezer. I'd be happy to kind of point you in the direction that I went, and I think LifeNet might have a couple potential solutions for you as well. So with that being said, I'm going to turn it over here to our last speaker tonight, Dr. Gail Childers. I had an opportunity to meet Gail as well as Brad here the last couple of years and got to know them better through our research on the Oragen material. Gail practices over in Jersey, Philly area, and he's a dual certified periodontist and dental implant surgeon. He's done some teaching at the University of Penn before and been very active with the Board of Periodontology and his local Periodontal Association. He as well utilizes the latest in technology to help help him optimize his case outcomes for his patients. So with that, I'm gonna stop sharing here, Dr. Childers, and can take us home here tonight.
Thank you, Michael. And great presentation. It's great on practicality. It's there is a learning curve with this, and you did a great job reviewing it for everybody. So what I want to do is share with you my experience. I want to show you a case that we've done, and this is 50-year-old. He was being seen for treatment of basal cell carcinoma at the University of Pennsylvania. He was on trazodone for stress and also Zyrtec for allergies. This is involves the maxillary anterior region of his mouth. You can see here he has porcelain fused to metal crowns involving teeth 7 through 10. Eventually, he would want to get these fully restored, but we were dealing with this media problem that he had. And you can see the apicea tooth number 10 here. It has a periapical cyst-like lesion present, and it's evident. So the ideal treatment was to remove the tooth and treat the radiolucency. And upon reflecting a mucoperiosteal flap in this area, you can see the dehiscence and fenestration of the root here. And this is partial enucleation of the cyst-like lesion. Now, this was basically a through and through defect to the palatal. So it was a large type of area. Michael said later it's like site for a molar region with the amount of 1.3 cc's of the Oragen product. You can see here, this is the Oragen in place. You can see the cortical fibrils here. You can also see some remnants of some type of foreign body that we do see with the black. So what I do routinely with these cases, I'll place the Oragen, prepare like Dr. Hartman said, and then I'll cover that with a bilayer membrane. First is a collagen, and most likely I've been using a pericardial membrane, and then cover that with the amnion chorion membrane. You can see here sutured with monofilament suture, and this was patient had a flipper made by his general dentist. I relieved, so there's no pressure on the area. This is about 3 weeks healing, and then from the occlusal, you can see this here as well. So we got some primary closure on this, granulating in. And what we did is I let this sit for about 4 months. I took a follow-up CBCT, and you can see the robust amount of ossification in this area, which I was really, really excited about when this happened. And we then decided on going ahead and doing a guided surgery for this. So this was the surgical guide that we had manufactured. And I did a trephine, 2mm trephine, and we got the core bone at 4.5 months. And then we submitted that to LifeNet, and Donna did the histology down there at LifeNet. She did a great job. When we look through these slides here, you can see we got H&E stain and a Mason's trichrome. Mason's trichrome lets us see more active bone formation, and we can both compare the central area of this explant bone. You can see here that the mineralization of the mineralized bone here, and you can see the osteocytes that are just basically on top of them. And you can look at the empty lacuna up with the black, both on both the H&E and the trichrome stain. And also you can see some blood vessels there. So again, at 4.5 months, you can see a lot of osteocytes here, as Brad alluded to in his presentation. We are excited about this histology that we do see. And we also see the implant lamellar bone being laid down with the osteocytes present. Again, another comparison between H&E and the trichrome stain. New bone with the osteocytes being laid down. You can see the red arrow there, and the lamellar bone with the empty lacuna with the black. So very, very exciting to be seeing this type of healing and histology. Again, you can see the gradual mineralization on the left-hand side, which you see more new bone being laid down. And the bone's being laid down and it's on top of it. So we found new bone is connecting with the implanted graft materials, which is really great to see. Presence of the osteocytes and lacuna with newly formed bone versus empty lacuna of implanted bone. And you can see the gradual mineralization of the new bone with the color red of the bone versus the blue of the non-mineralized bone. So with this being said, we see the histology. This is what it was like. This is when we inserted the implant. We did an Ostel reading on this case. So we kind of got an idea about 3 months. And this is the implant being, we did a CBCT, the implant being restored. And then here's the time sequence of the radiographs from, like I said, about a year ago, 4/12 to 23 to September when the temporary was made. And then there was a final that was done in December. So start to finish with this type of defect was beautiful. And here's the final radiograph and a final clinical photograph of this. And he consequently worked and he retired to South Carolina. I just heard from the general dentist down in that area. And they went and they're going to restore the other 3 anterior teeth for him. So this is our group here, plus Candy Keeney, Dr. Hartman, Dr. McAllister, and Dr. Elshard. And the variable types of defects you had heard that between Mike and Brad, they talked about periimplantitis, failed implants. And according to date right now, we have 67 cases. 10 of them with our group, there have been 10 titanium cages done, 9 sinus lifts, 20 horizontal ridge augmentations, 3 failed implants, 20 GBR cases, 1 vertical ridge, 4 periimplantitis cases, 2 mandibular vertical horizontal ridge defects, 2 maxillary anterior socket ridge repairs, 1 anterior nasal floor repair and a vertical ridge augmentation, and 3 maxillary anterior vestibular tunnel grafts performed. So these are the type of cases. These are 3 of the cases that I've done examples of titanium meshes. We saw earlier tonight periimplantitis on the tooth number 9 here, and also another maxillary huge anterior defect here. So we are also involving ourselves in this multi-center safety, efficacy, and use of Oragen cellular bone allografts for sinus and ridge augmentation prior to dental implant placement. That's our group. Dr. Hartman is doing a paper, use of cellular bone allograft, the posterior maxilla and mandible augmentation. He's submitting that Q3 to the compendium. And I have the case you saw today, and also another case. So we have the histological and clinical evaluation of the anterior maxillary defects utilizing the cellular bone allograft. So that's where we're headed. That's what we're up to right now, and this is how we're progressing.
There's some questions, and we'll first start out with one. This sort of would be directed at you, I think, Mike, and it was asking to describe sort of how you use the material with the mesh and the screws. I think it was getting at, did you put the material in and then place it on, and then finding your screw holes? Maybe you can elaborate just a little bit on how the material holds together nicely and helps when you're taking your whole mesh. And
yeah, sure. So first thing we typically do is just trying the mesh on its own to ensure that it's an accurate fit. Once we do that, then I take it out, and then we'll pack the CBA on the underside of the mesh, and then just a little bit of a light pressure then to sort of compress it then over the ridge. My assistant will hold it in place, and then that patient-specific type mesh, those screw holes that they have, I think they're like 1.5 millimeter diameter. The fixation screws that I use are 1.7, so it kind of catches in that mesh a little bit. So I try not to use those screw access holes. I'll just use some of the weaving or the interlace of the area. My drill and the screws fit through there, and I just kind of drive one through the occlusal. The one was a little bit of a longer screw, like a 10 millimeter. So I'll try to tack it in place with that. Then I'll try to get it at a different angle there, more posterior. And like I said, usually 2 is fine as long as I can kind of, put a little pressure on there. It doesn't wiggle around. I'm good with that. Obviously, with these cases with the vertical ridge augmentation, especially in the mandible, sort of that tension-free closure is key. So I ensure I do that. And I honestly, like I said, I use the collagen membrane because I feel like it may prevent the overlying soft tissue from getting so interlaced into that tie mesh. And it's always a challenge to get the mesh out. I feel like it doesn't get as tangled up when I do that.
Excellent. Well, another question, this one, Gail, I'm going to send your way.
Okay.
The question is regarding particulate size and what you do if you have larger pieces, I think was the question, how you're handling that end of it, the particulate sizing, if you have any comments on that.
Yeah, what I do is usually if there's really big, like Mike alluded to the fact that when you go express the get rid of the cryopreservative, if there's any hang up, I usually take them out, I tease them out, and I can always take like rangiers and break them up and use that. Depends on the type of defect. Like the big types of defects, you can also take those larger pieces and put them deeper down into the defect, so they're not superficial. If you do leave it superficial, you do have pieces that can fenestrate through the membrane and through the tissue, which is sometimes a little bit discomforting for the patient. That's the one thing that I've learned to work with as we've done about 23 cases here in the office. So that's why I like to cover it with a membrane, and then also make sure that none of that is surfacey to where the operating area is for exposure regions.
Yeah, I think that's a really good point, that the membrane and thin tissues can be extremely advantage. If it is a really nice thick case, I think having just the mesh, and I think no membrane or a membrane that has perforations is probably valuable. Just because of the revascularization with the larger defects. So another question that maybe we can all 3 answer just with our experience. I'll start it, but what's the feeling as far as the rate of regeneration, and are we placing implants sooner than we typically would? And I'll kind of start out. The study that we did in the sinuses, I'll be honest, I was a little leery with these eggshell sinuses, and I felt like an eggshell sinus was always a 6 to 9 months proposition, just because if it's 100% regenerative bone that you're placing implants in, you want to give it some extra time. Our research showed that really anywhere in that kind of 3 to 4 month time frame, there was quite excellent bone formation, and we were able to get really good implant stability. So I think certainly there's enough histologic evidence to support that it is accelerated. But at the end of the day, it comes down to what the clinical opinions are. And so for me, I definitely feel I can step it up, a month or 2 quicker than I might with regular one. What about you, Mike? What's your sort of time frame? I know you waited 6 months for the one, but now that you see that histology, do you feel a little more comfortable speeding that up, or do you still want to be conservative? What's your time frame?
So my kind of rule of thumb here has been if I'm using this material in lieu of doing like an autograft or an autogenous graft, then I still wait a little bit longer, 5 months, 6 months. I'm not in a big rush to get back in there. And like I said, I have been tending to use these for bigger defects. I have a few now that are more kind of just like larger radicular cysts. I think I'll probably do those, Brad, and the 3, kind of the more standard 3 or 4 months. But for the larger defects, it's such a big procedure. I think setting expectations with the patients at consult in terms of this is going to be a process. I think you probably could, but I don't want to be the one to push it on this one. I'll let you guys do it.
Gail, your comments as far as timelines?
Well, I like to use my CBCT and evaluate the bony architecture to see how we're doing. And I think from being involved with our group here, I'm pretty happy, waiting, about 4.5 months before I go back and do it. Normally I would wait 6 months. Depends on where the area is, depends on how much vital bone you think we need. But I think that, in some cases I step it up a little bit. In some cases, I just wait a little bit longer. Depends a lot on the patient, and that's I take it on a case by case basis.
It's a
I
good
think that's a
point.
really good point in that there is that patient variability, and the CBCT is obviously our best mechanism for evaluation, and our histology supports that what you're looking at on a CBCT is a regenerated bone. Unlike if you look at a CBCT of xenograft, it can look inviting, but you get in and it may have zero bone and just be residual particulate. So great point. Another question was related to if you can overlay PRF with the graft. And I'm going to kind of comment on that just because I didn't touch on it on our recent mesh paper, but I think anytime we're doing, shall we say, complex regenerative cases, I think PRF, PRP, PDGF, all of these have clear soft tissue advantages, and much like use of the amnion-chorion membrane, very similar kind of strategy in that we're trying to improve our soft tissue healing. So I think, and we'll get you guys to comment, but I think that we all would agree that adding these types of things can help with soft tissue, maintaining closure and integrity of the soft tissue, even if it's not over a mesh. It's important that these don't open up. And so I think the soft tissue healing is really important. So anything you can do to enhance that makes sense. So you guys want to comment on that?
One thing that I think that I've been happy with is using an amnion-chorion membrane. I think it's fabulous. It helps the epithelialization. There's a lot of growth factors there that we have that can enhance our wound healing. The other thing that I wanted to bring up is our titanium cage cases. I want to make sure that the participants know that we really need thickness of soft tissue. So sometimes before I do a titanium cases, I'll have to do a connective tissue graft. So make sure there's enough connective tissue there, because you got to get primary closure, you have to tension-free closure, you got to make sure you have enough keratinized tissue so you don't have any penetration of the titanium cage, particularly in the mandible. I figure that's where it's a little bit higher risk to use a titanium cage case. So just those little tidbits of helpful knowledge can help a lot.
Mike, you use either PRF or PDGF or soft tissue grafting?
Yeah, don't do any soft tissue grafting on these cases. Like that first one I showed, we do use PRF and like the sticky bone. There just adds a little bit more of the host components to the Oragen. I typically just use the collagen then over the mesh. I don't put the plugs then, the flattened plugs. Sometimes I kind of worry about creating some dead space in there, and that's just the way I do it. I mean, there's a million ways to do this, I guess.
All right. Another question that was asked is expanding. In your case, Mike, you had used actually 2 units. Let's say it was sort of a surprise and you only had ordered 1 unit. Maybe we can each comment what we would do to expand the graft material if you were in a situation where you really needed a little bit more material. You can layer it, you can expand it with materials. Go ahead and comment what your to-date routine has been.
Yeah, I'll go first here, Gail. So I'm a huge fan of another LifeNet product called OsseoFiber, which is essentially the demineralized fibers. That I've been using that for my sort of molar socket grafts for the last couple years. Really very happy with that. So in a case where I'm coming up maybe a little short on an Oragen graft and I need a little bit more, we typically then just open like a half or a cc of the OsseoFiber and then kind of mix that all together, and it handles all about the same. It stays together. That's what I do.
Gail?
Yeah, I agree with Mike. I've been using, I'm a big fan of that as well, and I just love that material. It's simple, it's easier to use, and it handles really well. There's really no down. It said in a lot of my single tooth molars where I'm not going to do immediate implant placement, I'll use the Osteofiber Plus there because it's a gem. It's really, and you don't need to use a membrane with that as well. You don't have to cover it with a membrane a lot of times.
There's one additional comment that I will make on that. I did in my earlier experiences, not with Oragen, but with other cellular bone allografts, use xenografts. We know xenografts are very good from a dimensional stability. And interestingly, it didn't give very good results. So that's one thing that I wouldn't advise. I know a few of our team members that aren't here tonight have at least expressed interest in playing with that. But my experience was that xenograft expansion didn't work nearly as well as allograft expansion. And that was consistent with what I found also with BMP2. BMP2 didn't work as well with our xenografts as it did with our allografts. So kind of an interesting finding with that. And the histologic, I've got some interesting histo on that, and I know Steve Wallace published on that. So I'm not the only one that's seen that, but that would be my only additional comment maybe to make. Shifting gears to another question. This is kind of a fun one because I would encourage you to come to the AAP. The question is, do we think this is the gold standard, considering that it uses all three processes to obtain bone? No more autograft necessary. And the AAP has a session, a general session this coming fall, and that is the title of the session is, basically, is autogenous bone still the gold standard? And I'm going to be one of the speakers. Craig Mish will be there. There's another speaker as well, Shinya from Japan, that will be speaking on FGF2. So it'll be kind of a fun session to talk about it. As I mentioned at the start, I still use autogenous bone, but I typically just use localized harvest as opposed to big harvest. So for me, it has replaced bigger harvests of autogenous bone in the sense of I don't go to the symphysis anymore as a standalone procedure. If I'm doing a lower anterior implant, I may take bone from the symphysis, just make my flap a little bigger and take localized bone. So still use autogenous bone, but not the bigger harvests. And I haven't done an extra oral harvest in years. I've done some of my own in the tibia, and I had an orthopedic friend of mine who did hip harvest for me. And we just haven't done any of those because once we've been using this, we've had great results without having to go down that pathway. So I don't know what you guys think as far as the gold standard, but it's kind of a fun question. Gail, your thoughts?
I think that, I think we're moving in a direction that we didn't know about. And it's exciting. I think our results are promising. I think that, as we keep going along this road, that we're going to see, exactly how we're doing. And I'm just amazed at the cases that everybody's doing and also the histology that we have now. So I think I think the gold standard is going to be changing, Brad, from what we see. We advanced from BMP2, like your whole presentation was great because you took us from where we were to where we're going. And, the BMP2, the stem cells, which aren't, predictory as to what cells we're going to get. But now we have these cellular bone allografts that are going to give us bone, that we need bone. And that's what I think that's going to be, it is going to turn into the gold standard, but we're changing a paradigm. There's a paradigm shift that we're in the midst of. And it's just promising, I feel.
Mike, any additional comments on gold standard?
I don't know. I think autogenous bone is going to be pretty hard to top in terms of the regenerative ability, but I guess maybe the first question I would have is, what do you consider the gold standard? What are the criteria that, is sort of your top three? And when you're thinking about what is the gold standard, is autogenous bone definitely has some advantages of the regenerative material, but it also has some disadvantages for the additional surgery time and the donor site morbidity and additional costs. I think a lot of it's probably going to depend on the size of the defect that you're trying to regenerate with, say autogenous versus the CBA. I think the CBA will have a good place in our regenerative armamentarium, especially for those of us that are primarily interested for regenerating bone for dental implant rehabilitation. So I don't know. It's promising. I think it's great that we have products like CBA. I don't know if it's going to be gold standard, and quite honestly, I don't know if I'm smart enough to really understand exactly what the gold standard would be. So I think it's great. It's a good product. It has saved me from having to do some other autogenous grafts. So I would say it's good. Try it.
All right. So last question was what you can do as far as storing the material if you order it and you have a cancellation. And I know, Gail, you mentioned the possibility of returning the material. That is one option. The other option that I'll just mention as a solution, I have put the material in what comes with dry ice. So basically, you've got a box that's like a cooler, comes with dry ice, and you can supplement that dry ice. So as long as you keep it on dry ice, you can reschedule your surgery a few days later or even a week later, just keep adding it to it. So it isn't always necessary to return. It does come 72 hours. So if it's shipped overnight, there's 24 hours. And then if you ship it the next day, it still probably makes it back okay. But like I said, we've just added dry ice, and that's oftentimes worked quite nicely to buy us a little time until either our next case or the patient rescheduled. But I think that's it for the questions. If anybody else has one, type real quick. Otherwise, I think we are going to adjourn for the evening. And I want to thank everybody for joining us, and really appreciate listening to you guys. Great presentation, Mike and Gail. And thanks, Ralph, for the introductions. And we'll look forward to more presentations and more research. You saw that we've got a lot of cases, and we're putting all of that data together. And it's, I think, going to be exciting to see the results as a group.
Dr. McAllister,
Yes.
can you hear me? Ralph
Yes.
Coosby here. Thank you for those comments to you, to Dr. Hartman and Dr. Childers on behalf of LifeNet Health, and all the participants and everyone listening in. Thank you so very much. This was informative. It was timely. And I think certainly a very big topic of interest. And we are very grateful to you and very much appreciate your time and effort and willingness to share your expertise and experience with us today. So very much appreciated. With that, I do have a couple members, Elena Janulis, I have David Adamson, and a couple of the members from the LifeNet Health team. Unless anybody else would like to say a few words in closing, then we'll end the session. Anyone else?
I just wanted to thank everybody for being here tonight, for joining us. Thank you to the presenters. You all did a fantastic job. And, we look forward to hearing more as we continue to build out our knowledge base on Oragen. And thank you for joining us for tonight. And thank you for an outstanding presentation.
You're here.
Sure.
Yeah, thanks, everybody.
Thanks, everybody, for
Thank
joining.
you.
Have a nice evening.
Okay, great. Take care.